Antepartum hemorrhage is the pervaginal bleeding occurring from the 20th week of gestation till the completion of the second stage of labor. The pervaginal bleeding has been divided into the three types according to the gestational age. If the baby bleed occurs from the conception till the 20th week of gestation, this is termed as abortion. Similarly, if the bleeding occurs from 20th week of gestation till the completion of the second stage of labor, this is known as APH or antepartum hemorrhage. The baby bleed occurring from the second stage of labor till 42 days after a delivery is termed as PBH or postpartum hemorrhage. Antepartum hemorrhage is caused due to several disorders. The placental causes include placental abruption, placenta previa, vasa previa, and marginal hemorrhage. The bleeding disorders include the von Willebrand disease and disseminated intravascular coagulation. Placental abruption is the pervaginal bleeding occurring from a 20th week of pregnancy till the completion of the second stage of labor following the premature placental separation from the uterine wall. This premature placental separation occurs due to all those causes which stresses the uterine wall, for example, increasing parity, multiple gestation, polyhydramnios. Besides, smoking and the cocaine use also leads to a placental abruption. The patient with a placental abruption presents with a painful dark or the bright red vaginal bleeding. Besides, if the patient has very severe vaginal bleeding, she may present in shock. On examination of her abdominal examination, the symphysiofundal height is found to be greater than the gestational age as the blood is retained within the placenta. The uterus or the abdomen is hard or tender. The fetal heart sounds are difficult to hear and the baby may or may not be dead. The pervaginal examination is not performed until and unless the placenta previa is ruled out at the ultrasound examination. On post-speculum examination, the blood clots are found within the vagina, and on rupturing the membranes, the blood-stained liquor is obtained. In some cases of the concealed hemorrhage or the silent placental abruption, little vaginal bleeding is seen, as in this case a retroplacental clot has been formed, which is diagnosed only after the third stage of labor attached to the placenta. On investigation, the ultrasound is regarded as the investigation of choice. Besides, the supportive investigation can also be performed. The management of the placental abruption requires resuscitating the patient to stabilize her. This requires 2 IV line whiteboard cannulas and taking the blood for investigation, arranging the 5 units of blood. Until the blood is arranged, the patient is transfused with Hartmann or the colloid solution. The foot end of the patient is elevated, oxygen is given, IV analgesia is also given. The definite treatment of the placental abruption requires delivering the baby as soon as possible through the most safest route, either by C-section or by the spontaneous vaginal delivery. SVT is preferred if the fetus is dead or the chance of survival of the fetus is very less. If the chance of survival of the fetus is more and the patient is presenting with a very severe hemorrhage, then the C-section is performed immediately. If the fetus is already dead but the abruption is so more that the chance of survival of the female is decreasing, so in that case again the C-section is performed. Fresh frozen plasma, whole blood or the fresh platelets are transfused in case of coagulopathy.